Hello, my name is Johanna Belazier, and I'm going to present information on the Cataract Guidelines published by the American Optometric Association.
Good evening, Johanna. This is Justin, and I will be doing the peer review on your presentation on the Cataract Guidelines published by the American Optometric Association.
My objectives for this presentation include providing the definition of cataract disease, providing the purpose of the guideline, providing the diagnostic criteria needed for diagnosis of cataracts, providing the diagnostic testing needed for diagnosis of cataracts, the recommended management strategies for cataracts, previous version differences, and the difference in the American Optometric Association versus the American Academy of Ophthalmology.
Great job with the outline of the presentation for cataracts disease. I think it's important to have an understanding of the structure about what you're going to learn, and you placed it in a very nice, organized pattern, easy to understand. And it shows right here in the beginning that it is important both to understand the disease itself, but also how to diagnose it and treat it and follow up from there, and what type of providers or the best resource to have as nurse practitioners. Great job.
The American Optometric Association is the organization that published the Optometric Clinical Practice Guideline Care of the Adult Patient with Cataract. This guideline was published in June of 1995. It was then revised March of 1999 and then reviewed in 2004. This particular guideline was written by the American Optometric Association Consensus Panel, which consists of ophthalmologists and medical doctors who came together to write the guideline. The strength of this guideline includes the inclusion of several different studies to back up what is in the guidelines.
Excellent introduction to the practice guidelines, and also great introduction to the American Optometric Association. I found a great statistic on the website of the American Academy of Ophthalmology. It states that cataracts affect more than 24.4 million Americans age 40 and older. By 75, approximately half of all Americans will have cataracts. So you could see how important these guidelines are to incorporate into primary care. And this type of little case study you did will help improve standards as far as detecting this disease.
According to the American Optometric Academy, the definition of a cataract is an opacification of the lens that leads to measurably decreased visual acuity and/or some functional disability as perceived by the patient. The wellness state would be a cataract-free lens in which the nucleus, the cortex, and subcapsular areas are free from opacities. The subcapsular and the cortical zones are free of dots, flecks, vacuoles, and water clefts, and the nucleus is transparent, although the embryonical nucleus may be visible. So basically, I have here a picture of a healthy eye, which you can see how the image of the apple is clear, and in comparison to an eye that has cataract, where there's clouding of the lens, and that projects a blurry image.
Very thorough explanation of the definition of a cataract disease. This must be very frightening for most patients. On the American Optometric Association website, it notes that cataracts generally form very slowly. And as you mentioned, you have the blurred or hazy vision with the descriptions that you have listed here on the slide. Also, they have trouble seeing at night with glare from lights. So the patients may associate this with just getting older and kind of push it to the side or brush it off. But it is very important to have guidelines like this so that primary care clinicians, such as nurse practitioners, can help detect even the most minute change to their patient.
The purpose of this guideline is to describe appropriate examination and treatment procedures to reduce the risk of visual disability from cataracts. The guideline contains recommendations for timely diagnosis, treatment, and when necessary referral for consultation with or treatment by another healthcare provider as necessary.
Excellent explanation of the purpose. I couldn't agree with you more that this guideline is important so that damage that could possibly be done by cataracts can be reduced. According to the actual guidelines by the American Optometric Association, they state the initial diagnosis of cataract may be made by a number of providers such as primary care physicians, optometrists, or ophthalmologists. And I think this statement obviously leaves out nurse practitioners. I could be biased, but I think this applies to any primary care setting, obviously. And it is our jobs to both prevent and educate, but also detect, like I mentioned in the previous slide, those small, minute changes to our patients. So that way we can filter them to the right resources, as you mentioned.
There are a couple of grading systems used as diagnostic criteria when diagnosing cataracts, which include the Oxford Clinical Cataract Classification and Grading System, the Johns Hopkins System, or the Lens Opacity Classification System, which can be broken down into LOCS, LOCS2, and LOCS3. A 4-point grading system modified from the LOC 2 is commonly used to grade the three different types of cataracts. So on the screen, you can see the three different types and how they differ. So basically, using this system, the nuclear cataract, which is when there's yellowing and sclerosis of the lens of the nucleus, grade 1 would be mild, a mild case. Moderate case would be graded as 2. A pronounced case would be grade 3, and a severe case would be grade 4. In the presence of cortical cataracts, um, which is measured as the aggregate percentage of the intrapupillary space occupied by the opacity. So in grade 1, the cataract obscures 10% of intrapupillary space. In grade 2, the cataract obscures 10 to 50% of the intrapupillary space. In grade 3, the cataract obscures 50 to 90% of the intrapupillary space, and grade 4 obscures more than 90% of the intrapupillary space. In the posterior capsular cataract, this cataract is measured as aggregate percentage of the posterior capsular area occupied by the opacity. So in grade 1, the cataract obscures 3% of the area of the posterior capsule. Grade 2, the cataract obscures 30% of the area of the posterior capsule. Grade 3, the cataract obscures 50% of the area of the posterior capsule. And grade 4, the cataract obscures more than 50% of the area of the posterior capsule. So each grading system, each diagnostic criteria for the grading system, they're different, but in this guideline, it was noted that the 4-point grading system modified from the LOCS2 is the one that's commonly used because in most clinical settings, reference photographs are not available. So that is just a less sensitive, but still um, quite accurate way to diagnose cataracts or to grade them rather.
Wow, my head is spinning from all those classification numbers. I had to pull out my graphing calculator and my protractor to try to piece the mystery together for the cataract grading. Of course I kid, but it just shows that it's very important to have guidelines such as this from the American Optometric Association that provides a wealth of knowledge from various professionals in the field. It gives the opportunity to the primary care physician or clinician, such as a nurse practitioner, gives them the opportunity to be able to diagnose these small changes in their patient's eyes and help funnel them to the right resource, such as these optometric professionals who can place them in the specific category or grade that they actually need. Great job giving the diagnostic criteria.
Diag- Diagnostic testing for cataract include a comprehensive eye and vision examination, which more info can be found on this topic on the Optometry Clinical Practice Guideline on Comprehensive Adult Eye and Vision Examination, with particular attention given to inspection of the lens of the eye. Essential elements of the evaluation include thorough patient history taking, paying particular attention to asking patients about whether vision loss was acute or gradual, as it is unusual for cataracts to cause acute vision loss. Asking the patient about vision problems under special conditions such as low contrast or glare. Asking patients about refractive history, previous ocular disease, eye surgery, trauma, and amblyopia. Asking patients about any difficulties performing tasks such as ambulating, driving, reading, and performing occupational activities is important. Ocular examination is another diagnostic test, and it's used to identify the nature and severity of the cataract and assessing any other diseases that might contribute to symptoms or limit the potential for good vision following cataract surgery. The guideline also mentions different supplemental testing that can be done, which includes inspecting visual fields, using an Amsler grid when you're suspecting macular disease, um, doing a corneal patchmetry and endothelial cell count, using a B scan, ultrasonography, doing a tomography, doing a specialized color vision testing, doing electrophysiology, doing a contrast sensitivity or glare testing, and doing a potential acuity test. So those are all supplemental testing based upon the particular individual and what you're trying to rule out that may be the cause of the cataract. Of these three recommended diagnostic testing, the comprehensive eye and vision examination as well as the ocular examination are the strongest because it will provide you, doing these things will provide you with your subjective and your objective data. And from your objective data, you'll be able to kind of stage and grade the cataracts, and you can rule out anything. And if you need further testing, the things that I mentioned from the supplemental testing can be done. But definitely the first two are the strongest when it comes to the diagnostic testing.
I like how you mentioned at the end of this slide that the comprehensive eye and vision examination, along with the ocular examination, are the strongest in terms of being able to figure out what is going on with the patient exactly. Um, that's why nurses are very good, and nurse practitioners for that matter, are good at gaining that information, getting a nice rapport from the patient, and we are able to come up with the evidence that is needed to make a diagnosis of cataracts, and then obviously like previously mentioned, refer them to the necessary next step if treatment is warranted beyond the primary care setting.
Diabetes, certain drugs like promethazine and other thiazines and chlorpromethazine, as well as corticosteroids, have been associated with cataract formation. UV radiation, smoking, alcohol, and nutritional factors such as not taking enough antioxidants such as vitamin C, vitamin E, and carotenoids can place you at an increased risk of cataract formation. So, the treatment for non surgical patients are basically patients that have few functional limitations as a result of the cataract, and surgery is not indicated, and it may be appropriate to follow the patient at 4 to 12-month intervals to evaluate eye health and vision and to determine whether functional disability develops. So this is just basically a patient who, they may have cataracts, but it's not affecting their activity of daily living. So we just kind of watch and monitor them. Um, Non-surgical treatments include um, the initial treatment for symptomatic cataracts may include changing a spectacle or contact lens prescription to improve vision, or incorporating filters into the spectacles to decrease glare disability, advising the patient to wear wide brim hats and sunglasses to decrease the glare, and dilating the pupil to allow for viewing with more peripheral areas of the lens. For surgical patients, this is a patient that they have to have surgery. There's no alternative to make the cataracts better. So the patient should be provided information about findings of the eye, the options for surgical interventions, and any factors that could adversely affect post-operative visual acuity or ocular health. Surgical treatments include small incision cataract surgery or extracapsular surgery. Those are the two different surgeries that can be done to remove the cataract from the eyes.
As future nurse practitioners, it's always going to be very important to identify the risk factors in each patient's life. Every case is unique, so you need to get a solid background to the patient's risks each time you visit a new patient. And like you mentioned, there could be a potential drug risk factor that's causing or exacerbating the cataract disease condition. So if it is found, it needs to be or it needs to be stopped immediately, so that way the progression of disease isn't allowed. You always want to go with the non-surgical treatment options first, of course, because there's always risk with surgery. Um, and actually, there's a great table in the American Ophthalmic Association guidelines that you provided that talks about postoperative complications, and there's quite a number of them. So getting those nice risk factors and having a solid list to, you know, cross your T's and dot your I's will always put the patient in better health outcomes.
So there was no previous version available for this guideline from the American Optometric Association. This guideline was created in 1995. It was then revised, but there are no previous versions.
As you stated, Johanna, there's no previous version for this guideline. However, if you are interested or anybody else is interested, there are a Canadian and British version of their own cataract practice guidelines. So if you want to compare and contrast, go right ahead and use the Google.
So some key differences that I noticed, the American Academy of Ophthalmology is another organization that put out guidelines for cataracts, but they did that in 2016. So the American Academy of Ophthalmology, the AAO, cites hypertension, obesity, family history of cataracts, and lower education as increased contributing factors to the development of cataracts. I know in the American Optometric Association, they did not state hypertension, obesity, or family history, um, or even lower education as a risk factor, but they did cite things like drugs and diabetes, and the things that I mentioned in the previous slide. So that's a difference that I noticed. Also, the American Academy of Ophthalmology discusses how the presence of diabetes, hypertension, obesity, and metabolic syndrome, which is a combination of diabetes, hypertension, obesity, and hyperlipidemia, have been reported to show an increased risk of cataract in multiple observational studies. So that's another thing that the American Optometric Association did not mention, those very popular diseases and their role in cataract formation, very common diseases rather. The American Academy of Ophthalmology included the assessment of tear function and optical coherence tomography in the list of supplemental testing. So the American Optometric Association did include a list of supplemental testing, but I noticed that tear function and optical coherence tomography was not on that list. So those are just some key differences that I noticed.
I'm very surprised that the American Optometric Association practice guidelines didn't include hypertension, obesity, and family history as risk factors for the development of cataracts. Reason why I was surprised is because, as we all know, hypertension and obesity is running rampant in the US population today. And I found a couple good statistics on the CDC website, one stating that more than one third or 36.5% of US adults have obesity. And also from the CDC website, about one in three US adults, or about 75 million people in the US, have high blood pressure. And as we all know from primary practice, these two conditions cause so many other secondary conditions that's too hard to list. So it is very important to have the guidelines include these two risk factors to help lower the chance of developing potentially cataracts or further making them worse.
This guideline is important because as future primary care NPs, we're going to take care of patients with cataracts. So it's important for us to know what to look out for and when to refer these patients to specialists. It's also important to know the importance of health prevention and health maintenance because a lot of the contributing risk factors to cataracts are preventable diseases that we can help our patients so that they can maintain their health and avoid, this problem in the future.
Johanna, I've really thoroughly enjoyed your presentation. I think you did an incredible job explaining all the necessary details for the guidelines on cataract treatment for adult patients. I also think that it's very important as primary care nurse practitioners in the future that we take the opportunity to get ourselves familiar with these guidelines and figure out the best ways to detect and manage patients that have these type of diseases, and also, like you mentioned, implementing a preventative type style of healthcare to help reduce or start to eradicate these type of issues that can be prevented by avoiding risk factors and implementing good diet and nutrition. Again, I really enjoyed your presentation. Thank you for sharing.
Thank you for listening to my presentation, and these are my references.